Okay, sorry for the delay, but I guess it's not my fault. It's probably yours anyway. So this thing had to be earlier, much earlier, but we needed to move around and change things. What I'm going to try to do is just illustrate to you the process of cab inspection. Some of you have been through that, but probably many of you haven't. So we will start from the beginning. One of your colleagues asked Dr. Hand to tell you exactly how to move, how to get started in the process. The process starts with looking at what you are doing. You've heard about College of American Pathologists. You like the system. You want to get started. You start by looking at your procedures, get your procedure manual, validate all your tests, subscribe to PT, run everything for at least 6 months. Then you fill an application for cab inspection. It's a detailed application, asks you about all these data to show evidence, how you have been doing. The staff there at CAP review the data which you provided. And if they think you are ready, they will assign you an inspection window, a time frame during which you must be inspected, a time frame of about 3 months or so. At this time, once your application is approved, they start looking for an inspector or an inspection team to inspect your laboratory. So they will contact the state commissioner or the regional commissioner like myself or Dr. Basta, depending on the region. Here they will contact your regional commissioner for the area, which is Dr. Fadl in Saudi Arabia, and they will coordinate with the commissioner assigning a team. So the commissioner can recommend a team leader who might be from the US or might be from local folks, depending on the arrangement which you have with CAP. Some laboratories or their administration, their managers demand, for instance, at least the team leader be from the United States. Others don't mind. Now, the team leader is the key figure here. Once a team leader is chosen, the team leader is expected to set up a whole team. So the team leader then gets a whole inspection package from CAP. The package will include your data, all your details, your menu, your tests, your QC, whatever you have been doing. So in this case, the simulation which we are going to do assumes that I was chosen as a team leader by the commissioner. So I get the package for Kuwaiti National Hospital, let's say. And I look at the data. I familiarize yourself with everything you do in advance. If I need more information, I will call the lab director at the hospital and check with him or her to see what these details are, or what do I need to know more about the laboratory. Once we get acquainted and familiar with the process, then I set a date for the inspection. And in the United States, inspections are unannounced. We don't tell you when we are coming. You have a 3-month window, you know that window, but you don't know when exactly. So in that case, the team may drop in any time during those 3 months. Outside the United States, well, it's different because we have to travel and it involves a lot of logistics. So usually we pre-arrange a date. I call the lab director and we agree on a mutually acceptable date. And during this time, then I select my team. I look at your menu and I decide how many inspectors I have to have on the team. Let's say you have 4 or 5 sections. We normally expect every inspector, every team member to inspect at least 1 or 2 checklists. Most international inspectors are familiar with the process, they're experienced, so we can easily check more than 2 sometimes, 2 or 3. But on average, 1 or 2 checklists a day can be inspected. So based on that, we choose the team. Now, when we communicate with CAP, the staff have already studied also your information, and they give us recommendation on how many team members you are supposed to use. So we try to stay within that limit. Okay, so I set up the team, I inform them, we give them their parts, everybody gets their checklists, we give them some pep talk, encouragement, whatever, reminders of what they need to look into, and we assign a date of travel and going to the laboratory, okay? So that's all set in motion. So we arrive at the laboratory. Part of the inspection, as you heard from our talks, is to look at the laboratory as a key element of the organization. You are not isolated, or at least we don't like to see the lab isolated from the rest of the hospital. So although we are coming to inspect the lab, we are interested in looking at the hospital too. We're interested in knowing the relationship between the lab and management of the hospital and medical staff. So part of the inspection is to interview a representative from the medical staff, usually the CMO, the Chief Medical Officer, and a representative of management, the Chief Executive Officer. So we do that either at the beginning or during the inspection, depending on their time. That's usually a very brief interview just to familiarize ourselves with the process. Okay. Let's start with that. I'm going to give another microphone here. So I come to visit the lab. I have here folks who agreed to start acting career. So Dr. Basta will act as the lab director. And please say your name. Muhammad agreed to play a technical supervisor. And Sadiq, a bench tech who is working in the laboratory. And I'm just going to try briefly to inspect Lab General. Now, this is my checklist, which I assigned to myself. So as you remember, Lab General has 2 or 3 main checklists. One is all common, that talks about items that pertain to every laboratory, to every section of the lab. And then Lab General, which talks more about general things for equipments and reagents and so on. And one about team leader, okay, I mean the lab director himself. So what I usually do, I start my inspection with, well, greetings and so on. We get in, I have the team. So the first thing is we do introduction into the laboratory. So we meet there, and okay, Assalamu alaikum, or morning, good evening, whatever the language it is, okay.
Dr. Napil, I am the lab director.
Mr. Muhammad, I am senior support.
Mr. Siddiq, I'm technical on bench.
Okay. All right. Well, thank you, folks. I'm Dr. Omar. I'm the team leader here. I run my own laboratory at the United States and have been assigned to inspect your laboratory. I want first to thank you for choosing the College of American Pathologists to be your accreditation authority here. As you know, the college's mission or method of accreditation inspection is different from other organizations in the fact that we are your peers. You run your own laboratories, we also run our own, so it's a peer-to-peer interaction. We're not here to police you, we're not here to judge you necessarily in a specific way, but we're here to work you towards quality improvement, and the goal is to make your laboratory just as good as any other laboratory in the world. If we discover any deficiencies, we will make certain that we inform you immediately of those deficiencies and help you correct them as soon as possible. There will be no hidden agenda, no secrets. So we hope that the process will go as smoothly as possible. We're going to start the inspection by walking through the laboratory just to give a feel of the lab. And then the inspectors will stop at their respective areas and start the inspection process.
Thank you for coming. We appreciate you coming here, and we hope you give us a good inspection. We can take a tour in the lab, and every supervisor will show you their areas, and then we can talk.
Okay, great. So that is the introduction. Now we introduce, so we will go together and walk through the lab. The first walk is just getting to know the place. Now, experienced inspectors, when they walk through the lab, don't assume they are just walking. Okay, we are really looking at things while you are walking, and we will come back to it. So don't get excited, say, oh, they overlooked this or not. This is just a brief. So we walk around, and we already formulate in our minds, what am I going to check first? The reality is, like I said, you have about 3,000 check items if you want to inspect a big lab. There is no way we're going to look at every item. So we have to be selective. And that's why we just prioritize things. Okay, so we went through the tour and we finished. Now what I'm going to do, I'm going to start with interview the lab director. That's how I do the inspection. That saves me a lot of time, a lot of headache. The lab director, of course, there's a whole checklist for the lab director. But more than that, I'm going to get a flavor of the lab. I'm going to understand the organization and get a lot of things out of it before I even start. Okay, so we're going to start the interview. Dr. Basta, well, it's good to see you again, and hope we can really understand a lot of things and help each other improve our laboratories. Can you just give me a rough idea about the organization of your lab first?
Well, our lab is a very busy lab, and we have a lot of clinical, and we also have anatomical pathology. I am the director, but I delegated everything to the chiefs of each department of those. So I direct, but they manage.
Okay. All right, well, thank you for this introduction. Now I have a good idea about the organization of the lab. Well, let me see how much involvement you really have in the laboratory. Can you briefly just describe to me your quality management program in anatomic pathology?
Well, I delegated this actually to the chief lab manager under me, and he took care of that. So I will ask him to bring it for you. Would you please bring all the quality management books so he can review it?
Now let us to start by our documents in our clinical pathology.
Okay. Well, that's okay. Well, thank you. What I'm going to do then, if you can collect those documents, I'll come to you later after I finish the talk with the lab director. Yeah. Okay. Well, Dr. Basta, I'm going to look at the details there. But what's exactly your role in there? Do you actually design the quality management program? Do you read everything? Do you sit with people to look through it?
I don't read everything. I just have them, do that, and I just sign it after that.
Oh, okay. Yeah, well, yeah. Oh, okay, well, I think let's talk about that. I mean, I understand that this is a different place, a different laboratory, and I respect your organizational structures. However, we believe that the best way to have a good quality management program is to start at the top with the leadership. Do you think we can change this process a little bit in the future so you can be the leader in designing quality management programs and work on them with the staff instead of the other way around? Instead of expecting them to tell you what to do, maybe you can design?
Would you be able to help me to show me how to do that?
Oh, absolutely, yeah. The quality management program starts with, or one of the key things is putting indicators of quality. So maybe we can go through the processes. You have the pre-analytical process, analytical and post-analytical. Say in anatomic pathology, we could start with the specimen quality. That's a pre-analytical. And we can say that the threshold or a benchmark for good quality specimen should be at 95% of the time. So we say the benchmark is 95% of the time, which means if we get more than 5% inadequate specimens, we have to talk to the clinicians and rearrange things and make sure they do better. Then we can set up a few analytical indicators For instance, we need to look at peer review, make sure that diagnosis is correct. We can make pathologists refer to each other a certain number of cases, like 10%, and document any deficiencies. And we can set a standard for discrepancies between them. How far or how much can we expect in terms of discrepancies? What do you think is a good number to expect to be acceptable in differences in diagnoses or challenge discrepancies between pathologists?
Well, according to ours here, sometimes we have different opinions. However, I think we should make the correct diagnosis.
Right.
So I will follow your way, and we're going to review about 10% of each one of us. We'll review the other one, and we'll make a policy with it that at least 10% of our work will review.
Oh, excellent. That's an excellent suggestion. Actually, this is a gold standard. And most good laboratories do require 10% peer review. And they set the error rate at, say, 1 in 1,000 or something like that. The benchmark is derived from understanding of the community, what is acceptable to other laboratories. You don't want to be worse than your peers, so 10% really puts you at the top. 1 in 1,000 or 1% rate of error is also reasonable, unless your staff want it to be more strict. But that's an excellent indicator. So then we go and set up a post-analytical indicator. For instance, turnaround time. Do you follow turnaround time in surgical pathology, for instance? Or do you think that would be a good monitor?
Well, we just wait on the immunostains to come, and then we review the case. So it takes around, a week to 10 days to turn a whole case out, like a colon cancer or something.
Okay, well, let's see how we can improve on that. The community standard is to divide surgical pathology specimens into those which are routine. They don't need immunostains. They don't need any extra workup. Those, about 80% of them are supposed to be within 2 work days. The others include those immunos or additional workup and so on, which are included in those 20%. So if we can design a turnaround time monitor, we could say we expect 80% of routine cases to be completed within 2 days.
I didn't know that, but I would work on it.
All right.
We can divide the work between us to have the routine cases finished by 2 days at the most, and the complicated cases, we'll give it a week.
Oh, excellent. That's another excellent suggestion. So you set here 2 standards for turnaround time. One for simple cases and one for complicated. One is 2 days, the other is 7 days. And certainly you can share that responsibility. You could assign a pathologist rotation once a month. One pathologist does the count and the statistics.
That's actually a good idea. We can add that. We have one of the pathologists always review the cases of the whole month and write in the end of the month his quality program, what he found, and then we improve it in the next month. How about that?
Yeah, that's a good idea. It depends on how often your clinicians expect the results to be available. Now, if you make a mistake, is 1 month too long to wait to correct the mistake? Suppose a pathologist made a mistake on diagnosis or a test came wrong. Do you think 1 month is too long? Don't you think it's too long to wait to correct that mistake?
Maybe too long.
Maybe too long, yeah, I think so. Because if somebody has lung cancer or breast cancer or something like that, you don't want to wait a whole month. So maybe the peer reviewer should do it, or the rotation should be maybe every week or every 2 weeks. And how we determine that, actually, you don't take my word for it, you could consult with your clinicians. Tell them, if you're a surgeon and you get a diagnosis of lung cancer or breast cancer, how soon would you operate?
Well, I don't talk to them, they don't talk to me, and we are like in a separate places.
Okay.
I just give them the report and they take care of it.
Well, I think that's another area of improvement. I'm going to make sure I talk to the CEO and CMO and discuss that with them, because we want the lab to be integrated within the hospital. But I think that would be a good way to arrange things so that results are ready in a week or so it can be useful. All right, well, excellent. So we arrived here, we just made an excellent quality management plan to start with only 3 monitors. But the expectation is that, like you said, you'll have every pathologist participating, maybe every supervisor will be participating. And by the way, this is how it's done for every section in the laboratory, not just anatomic pathology. Every section should have the same thing, at least 3 monitors, if not more. The section leaders should be part of a group which is called Quality Management Council. You meet once a month at least, and you review. You could change some of these monitors, add, subtract. So I think we are into something, and your lab will be outstanding by the time you start rolling this program. So I appreciate that, and as you see, we identified a deficiency. I'm going to write this as a deficiency that your quality management plan is lacking, and as a director, you didn't have until now direct involvement. But the fact that you immediately agreed to write a quality management plan, maybe you can write it by end of the day. We'll review it and it will be corrected on site.
If we write it now and we go over it, would it be a deficiency that's corrected and we have to forget about it?
Yes, if you write it and by end of the day we review it and I accept it, it will be corrected on site. It's a deficiency, but it will be corrected on site. Okay, so I think we arrived here at a good thing. Thank you very much. I think I've taken enough.
You're welcome, thank you.
I've taken enough of your time. I know you're busy. Of course, the laboratory has to continue to work. We cannot take your time all day. So if you are inspecting a lab, you have to be cognizant of the time movement. You have to stay on top of the event. If you are the team leader, you have to make sure that the team members also stay on target. So I end up here, my interview with the lab director, and I'm going to go now and inspect the laboratory. So I'm going to start at the bench, if you don't mind.
So I will go work on those now and
Yeah.
write them and make them ready, put them in the computer until the end of the day. He will look at them and make a decision if he will going to accept them or not. If he accepted them, it will record it as a deficiency on me, but corrected on site.
So don't.
The bench doesn't look good here, but all right. Well, he has a few tubes here, or at least one, few samples. Tell me about those samples which you have. Just go through the process with me. How do you get your samples, and how do you process them?
Yeah, actually, this batch I have received from outpatient through the pneumatic tube. I took them. I just separate them as CBC or biochemistry samples. Now I am matching each samples with the ID and the name and the code and the type of test.
Okay.
So I have to separate them well, segregate them, and match them well before handle it to the bench itself, to the section.
Okay, very good. See, I put my hands
It's
there.
the receiving area.
This is not just for now, for the talk. I do that during the inspection because supervisors always have this habit to jump in. They want to take over. So I tell them, no, hold on, I want to talk to him. I want to see the actual people who do the actual work. Okay. So yeah, you talked about the identification of the tube. Tell me, how many IDs do you look for?
Actually, I focus about 4 things, which is civil ID and the name and the test name of the patient, civil ID of the patient, test name and hospital number.
Okay, so you need at least 2 identifications.
Yeah.
At least 2. If you have more, that's fine. Okay, now you got the specimen. What else do you look for in the specimen?
The type of the specimen and if it is suitable, if it is unlabeled, or if it is a wrong sample or suitable sample for a test. So I have to, for example, if it is not unlabeled or not good or incorrect sample, I have to reject or to take an action.
Oh, excellent.
This-
So you have rejection criteria?
Yeah,
for
we
samples.
have rejection policy actually and distributed in each section and everybody involved in this rejection.
Can you
criteria.
please show me this policy?
Yeah, sure, absolutely.
Oh,
I have it.
Where is it? Is it hard
Yeah, it
copy
is.
or on the computer?
It is a hard copy actually distributed in the each benches.
Yeah, if you start typing there or looking for it, how long will it
Yeah,
take
we
you?
have the soft copy. It is there in the main computer and which is in the senior in charge office, and you can take and review it anytime. And we have a hard copy. You can have a look
I
on it.
guess this is a hard copy of pure
Yeah.
policy and rejection specimen.
Exactly.
And I'm looking here. Seems that the last time this was signed 3 years ago.
We have updated one actually.
You have an updated one?
Yes.
Okay, well
We
that-
do that reviewed by the head of unit and the senior in charge and signed by the lab director and chief technologist.
Okay, so what you want to do is make sure that the final copy or the one which is updated is available on the bench or
Yeah.
in computer.
No, updated one both in the on the bench and in the
Okay,
computer.
very good. So that's the idea. Just in case there is something which is not following that rule, we want to make sure it is available.
Yes, exactly.
One of the again here you're doing great, but again remember we are your peers, so it's our duty if we have something to improve on, to help you out, to let you know about it. It's not about deficiency, it's about recommendation. It's
I would
about,
appreciate that. Yeah.
yeah, it's about again helping each other do the best. You may have practices that I like, and I may take it to my lab, and I'm going to give you what I think can help you. For instance, since I suspected something is not current, the best way to keep things current is what we call the 1/12th rule. Have you heard of the 1/12th rule?
No, I haven't.
Okay, so you have in the year you have 12 months. And you remember how we said your quality management program should be reviewed at least once a year to make sure it's up to date. So you divide your procedures into 12 compartments, into 12 parts. And each month make it a habit to review 1/12th. So you assign the staff, well, you're not the supervisor, now the supervisor is listening, of course, so he's paying attention. So you assign 1/12th to some of the staff to review each month. And take it through the whole process. You review the procedure, update it, have it signed by the supervisor and the director. This way you are ready all the time. CAP accreditation is about continuous readiness. So make that part of your continuous readiness plan. Every month, 1/12th of the procedures is reviewed and signed. And while you are at it, you have CAP's checklist, same thing, divide them into 12 parts, because CAP revises the checklist once a year also. So every month, take 1/12th and review it with the staff. This way you are ready all the time. What do you think of that?
I don't know exactly what is the advantages of that if review it every month, if I will not add anything. Is that what you mean?
No, you're reviewing 1/12th only.
Ah,
You are divided in 12 parts. This way, the advantage that you are always ready. You don't wait until we tell you we are inspecting your lab to start running around and getting procedures. And
I get that. That's good.
okay.
I think every part we have to review the previous one also.
No, you don't have to. That's it. Just 1/12th.
One
Yeah.
review per year.
Per year, yeah. You'll end up with one review per year.
That's good.
If you want to do it,
reviews per 2 years, which is your time to be accredited.
yeah, because every 2 years you get accredited. If you want, you could divide it into 1 to 24th. But actually, you want it to be 1/12th. Why? Because at the end of the year, you are expected to do self-inspection. Okay, so when you do self-inspection, that's part of it. That's why we say 1/12th. So this is a quality improvement. Again, it's not a deficiency or anything. It's just a recommendation
That's
to you
good.
for quality
Yeah.
improvement. Okay, very good. Thank you. So now let's move the testing phase to look at other things. There are reagents lying around here. Can you pick up one of those, like this reagent?
Yeah, sure. Here it is.
Okay, let me see the expiration date.
Yeah.
Is it there? Show me. What is the expiration date?
The expiration date actually it is June 30, 2009.
2009?
2019.
All right.
2019.
Very good.
Yeah.
Yeah, so this is okay. It means it's within its expiration date.
Yeah.
Hasn't expired. But let's assume you are a histotech, and you may have a special stain there, hematoxylin using for the pathologist, and that thing has expired, but they are still using it. Okay, and they are saying, well, this thing doesn't expire.
Actually, no, we do not work or we do not use any reagent either if it is expired. Either it will work or not, but we will not use.
Yeah, good. So that's
So
the
we
attitude.
haven't tried before.
Yeah, that's the attitude. Everything should have an expiration date. However, we allow rare exceptions to situations like that, especially to the non-US laboratories, because some reagents actually don't expire because you use them to dilute to prepare a stock reagent. Some of them are those stains used in histology. However, the standard remains. You have to prove that they work. So we can make an exception to you in histology to use an old powder from which you prepare hematoxylin, or in microbiology, or wherever you use stains. But you have, before you use it, because it expired, you have to give it a new expiration date. You have to revive it, so to speak. So you take aliquot, you prepare the stain and validate it. You heard about validation. You prove that it works. You stain a few slides, show them to the pathologist, and have the pathologist sign saying this thing works. And then you assign a new expiration date to it. So that's a way, if you really must make an exception because you cannot buy a new reagent, it's too expensive, etc., you can expand the life on that. Okay.
So, can I ask you a question?
Yes.
If I'm gonna to make a new expiration date, depend on what? On I will just do control for this reagent which is expired or unknown. If it is okay, so that means I will make expiration date.
Yes.
And what about the stability also? How I can measure it by also controlling it? Make control every day.
Well, like we said, this is an exception, so you don't do it. The rule is if it has an expiration date by the manufacturer, you don't touch it. You don't change that. You must adhere to the manufacturer's expiration date. Now, if it doesn't have an expiration date by the manufacturer, like some of those powders, folks in histology, maybe they can show you, some of those powders don't have expiration dates. You are supposed to put your own expiration date, or they may have one, but everybody knows that it really doesn't go out of function. So in those cases, that's when...
But I think it's not expiration date, it's a stability on board.
Yeah, it tells you,
Stability.
it might be stability. It may tell you this reagent doesn't expire or stable or not. So you check that, and if you are convinced that it can be reused and you don't want to throw it away, I mean, we don't suggest that you use it if you suspect, but if you must, this is what you need to do. Yeah, validate. Take known positives and negatives and assign an expiration date, like give it another 6 months, and then do it again. Yeah.
Can I ask a
I
question
see.
on that?
Yeah.
What if we got 10 old specimens that we have slides on, and I recut them and make the stains, and I restain them, restain the new slides, and then compare the old one to the new one? If that can be done as a validation.
Absolutely, yeah, that's validation. You get 10 to 20 slides where you know the stain worked and repeat, and excellent, yeah. That's a way how to revive something that is stable. So again, we want to emphasize this, it doesn't talk about things in chemistry or hematology or other areas where you have a manufacturer assigned expiration date. Those must be used within their expiration date because they may not be stable beyond that. But from your experience, if you know a material is stable and you have a difficulty getting a new material, CAB makes a small exception in that regard if you validate it. Okay?
I see.
That is also assigned on the reagents. If you have some reagent and expired, and you can run it on the machine, auto analyzer with a quality control sample.
No,
Is it
no.
accepted?
No, it's not accepted. Again, if it has an expiration date, you must use it within the expiration date. Yeah.
Even if you have deficiency from the reagent.
Well,
Shortage of the reagent.
if it is one
And
of
you know
those,
that it's working.
Emergency.
yeah, if it is a critical reagent and you really have a problem with deficiency, like in China or some other places you heard about PT, takes weeks to arrive, and by the time it arrives, it has already expired. So the same thing if you got a reagent which is very rare and expensive. Yeah, you could make that exception. You could consult with CAP, and we will tell you whether we recognize that exception or not. Right now, the only thing where it's kind of acceptable is those reagents for staining, because they come in powder form. And we know they are stable. Anything else, if you want to make an exception, you probably need to consult with CAP staff. Most of the time, they will grant the exception if you really convince them this is the only way we can do it. Okay. But again, nothing is rigid as long as it's done with good intention. The intention is not to harm the patient. And if you are going to need this to test patients who must have the result, it's better than having nothing, but the standard still must be upheld, which is validation. If you can prove that's valid, unknown controls, then you can do that. You can get an exception. Okay. So you are good. Your reagents are fine. Let's move on to the equipment which you are going to use here. What do you have there? Sysmax or something?
Yeah, we have here Susmex, we have Vitek from Biomarine, we have
Okay. So let's take. Can you tell me when was the last time you did preventive maintenance on the Sysmax?
we have annual preventive maintenance, which is there is like Ministry of Health has a contract with the company. They come and do quarter maintenance for 4 times a year. This is annual, and we do maintenance like daily maintenance, which we have this logbook. You can see it. This is daily maintenance, so I have to check this machine is the power, the reagents, it is okay, can I find the display and the touch screen, whatever, there is no troubleshooting. So I have to write this down in the logbook, maintenance logbook, which is daily. And we have like, if we face any problem, we are trying to solve it. If not, we have to call the engineer. So it's depend
Okay.
on the
So
on the situation itself.
if you want to tell immediately, or if I want to know whether this was done, preventive maintenance done, is there a sticker or something right on the equipment which I can see?
Daily, we
No,
have.
not daily. For the preventive,
Annual?
usually is done annual.
Yeah, we have the report.
Done by the government, and we don't know anything about it.
No, we have a record doctor. We have
That's what I'm trying.
each machine has a file, specific file. Once the engineer will finish from this, I have to sign. Then I will take the copy, my own copy, so I will file it.
Yeah, this is an important point the lab director made here. He doesn't care, but he wants to remind you that that's not acceptable. That would be a deficiency if you don't know when was the last time preventive maintenance done, whether the government contracts for it or whoever. It's your responsibility. So my next question would be to you, okay, show me your log, or show me a sticker, or show me something that proves.
Yeah. I will show you the file for annual maintenance and daily
Okay.
maintenance logbook.
Okay, good. I mean,
It's available in the-
so yeah, they should be available in those cases. If I'm the inspector, I would really ask you to bring them and I will look at them. Most people put sticker on the machine.
Maybe the preventive maintenance.
Yeah,
is
prevent-
signed by the senior in charge.
Whoever put a sticker somewhere next to the equipment or a log next to it, this is the annual thing.
Yeah,
The
annual.
engineer does that, he will give a sticker, and he will sign his name, time it, and date it.
For the next, you mean for the next check?
For the day he did, and he will tell you next time he's coming, and he will take a record.
He's giving us a report, like a report.
Exactly.
The report maintenance.
The report
I will
must be
keep the
next
report
to you.
maintenance.
It must be next to, available within minutes, because I don't have time. You cannot tell me, well, I'll get it to you tomorrow.
Because
I'm
no,
getting
the
on there.
advantages of this report, he will write all the details which he done for this machine.
Okay. But so we understood again, like we said, this is not for confrontation, and we believe you. We are just trying to make sure we all
Yeah.
talk about the same thing.
I will show you the document.
And yeah, as long as you have the document available, I will look at it when I go back to look at the other documents. Okay. Well, excellent. Thank you. I'm done with the technical part. I'm going to move to the
Welcome.
supervisor. Okay. Now, I heard here about daily maintenance, and you can give him the logs, or you have the logs.
Yes.
Can you show me the logs for the last 10
Yeah.
months?
This is now the Sysmix machine. Okay, this is the serial number of the machine.
Okay.
This is the unit. It's related to hematology department. Okay, and this is the action done, the preventive maintenance action done.
The daily maintenance.
This is, you are looking for the daily.
Yeah, I'm looking for the daily.
Yeah, this is the start up and shut down for the machine.
Okay.
And if you want to check, you can check also on the log, the machine log. You can open the machine log, you will find the daily. And here the sign done by the one who did the maintenance.
Okay.
And it is signed also by the supervisor.
So this is your signature?
Yes, that's right. For the daily, we are checking it daily.
The supervisor checks
Yes,
daily?
yes,
Okay, that's
yes,
good. That's
yes.
good practice. We at least require once a month that you review what the technician did every day, but you go at least once a month.
We are doing
And
it
you
daily.
sign.
We are checking it
All
daily.
right, so this is for this month. I see supervisor's signature, and I look at the previous. Yeah, there is supervisor's signature. Excellent. Now here I see one, you probably missed it from last year. Okay, so one missing signature is not a big deal. It depends on how many are missing. If it's just one, it's not a problem. But let's say you have 2 or 3. What I like you to do is just go ahead and sign them while I'm here, and we will call it again corrected.
Maybe I am on vacation on this time, so I forget to sign. When
Okay, no problem. You just sign them, show me the signature, and we will call it corrected on site, because you are supposed to sign every month, regardless.
Sure.
And now, for me personally, most of the time, one missing signature, I ignore it. However, the standard is everything must be signed. So since there are 2 or 3, well, we'll just do it like that. You go sign them, and we'll call it corrected on site.
On site.
Okay.
I'll take it.
Very
on
good,
site.
excellent, yeah, good job. All right, let's move on here. Do you have a PT for any of the tests which are on
Yes,
this
we have an
machine?
external quality control. You are talking about external quality control.
Yeah, proficiency survey. Does
Yes,
your lab
we-
participate in CAP?
We are participating right now in the NICUS, but we will shift to NICAB
Yeah,
inshallah.
let's suppose you have been participating because we allowed you to be inspected, which means you have been at least for 6 months doing PT, proficiency surveys from CAP. Okay, which is similar to what you have, but you heard the talk about CAP, right, about PT, and you get the feedback
Sure.
from the college after you give them the result. The participant summary, it's called, which shows you your peers' performance, compares with yours.
I will show all of our proficiency
Okay,
testing.
so let's say here I'm looking at one of those, and I see that all your results are good, but there is somewhere there a trend, a positive trend on one of the analytes.
Actually, we did a corrective action here. We will check again the maintenance and the calibration and the quality control done on the same day, and we found all of the result is valid, and I can show you all of the result on the same day that we are running this proficiency testing.
Very good.
So I don't know, maybe the shipment of the samples, maybe the stability. I cannot really find the errors. What happened during this day?
Well, as
But-
long as you looked at it, what I am interested in is seeing an evaluation by the lab director. You are the supervisor, of course, and you start with the evaluation.
That's right.
So even if you had here everything 100% successful, I really like to see where you highlighted a trend. I mean, trend is not a failure.
A failure, yes.
It's not. We don't consider it a failure as long as you got acceptable result. But it is something which needs to be
It's
evaluated.
like alarm.
Yeah, fine tuning. It needs to be attended to. So what I like to see is a statement by you or the lab director saying there is a trend here, and this is, like you said, what we are going to do. I'm sure you did that, but that is the process for everybody. We need to see evaluation, even if everything is acceptable and there is no trend or shift. A statement must be made to that effect, to show the inspector that you are serious about evaluating your PT results.
Yes,
Okay. So that if you are not doing that, that would be a recommendation to do it. Okay.
Okay.
Very good. Okay. One more thing. While I was walking in the hospital, I was gonna meet the CEO there, or the CMO. And the CMO is an ER doctor. And he tells me that the last several potassium measurements, he didn't believe they were true. So he asked me what should he do about it, and I told him to talk to you. I don't know if he talked to you or not, but let's suppose he called
Yes,
you
if he
and
called,
said,
he talked to us, and we show him all of our quality management systems that we are did for the potassium. We have our daily quality control. We show him the maintenance of the machine. We show him the stability of the reagent. We don't have any expert, and we show him the proficiency testing, the CAP result, and all of CAP results are within the performance.
okay, then how do you resolve the discrepancy here? Okay, remember, now this is an error because somebody called and is telling you potassium is wrong because his patients are in bad shape. This is an ER or an ICU. And if you are showing him very low potassium, which means he has to give potassium to the patients, and that's dangerous. So he perceives that as a lab error. And you want to either convince him that it is not an error, or you want to do the checks which you
We
made.
have to do the checks.
The lab director has a question.
I think it would be better if we just repeat the potassium on those patients first and see if we're going to get the same results or not. And then I'll go back and I check if I get the same results. I'll go back and I check the pre-analytic. Did they take that from above IV and that diluted the specimen with the IV fluid, so the potassium came low because of the dilution, or they took it from a line that had, fluids in it too. So we'll just make sure, where they got the specimen and how they got it. And then I'll go to my machine, recalibrate the machine, do controls again, and then repeat the patient for the second time. And I see if I'm going to get the same results or not.
Excellent. This is a collaborative effort between the supervisor and the lab director. But we have to start with acknowledgement that we had a major, significant error, which means this error had the potential of causing patient harm, serious patient harm. So like we talked in the morning about the errors, you start there. You classified it as major significant, which means it requires immediate action. You notify the lab director, and here he got involved immediately, and he suggested a way. So you identified this, you classified the error, major significant. You wanted to identify the source. Like he said, it could be pre-laboratory from the specimen drawing from the line. It could be in the lab, machine calibration, running additional control, looking at previous QC charts, or it can be post-laboratory. Maybe the computer system messed up. Sometimes some computer systems, you put the correct result, but when it goes to the other side of the hospital, it goes somewhere else, or it gives a different result. But you see how the process works. You classify the error, you identify the source, you do look at the phase, pre-analytical, analytical, post-analytical. Immediate corrective action, like the lab director said, you go immediately repeat. You want to help the patient first. So you immediately correct it, then you go looking for preventive action for the future. So you look at calibration, details, maintenance to make sure this doesn't happen again. And then you come back and check whether the action worked. Okay, so that is the error management policy which we are looking for. Okay. Excellent. Well, thank you very much. So that's.
And then we're gonna call that physician again in the ER and let him know the new results, that the first was bad because of what? Because they draw it from the line. So we will tell the nurses not to draw anymore above the line. They draw from the other arm, not from the same arm of the.
Yeah, excellent. So that's another part of the immediate corrective action. You see how now the lab director got lived up. He got enthusiastic about getting involved. Because before, remember when he said he doesn't interact with anybody? That's the goal which we want to get. We want to help the laboratory. We want to work with you so you become yourself confident and important to the organization. So now, yeah, we'll call the physician there, explain to them how we do things. You want to explain to your peers how the laboratory works. Many of them don't know what you do. That's an opportunity for education. So you explain to them, and you get their excellent interaction. Okay. And before now I go back to check, see what I did now. I investigated the lab work directly with the players. What I do after that, I retreat to my workspace and I pull the checklist. That's the only time I use the checklist directly. Now, some inspectors may carry the checklist with them and go read one by one. It will take you more than one day, certainly a whole week if you want to go through every checklist. So once you get the hang of it, you don't have to do that like you saw how I got what I have in mind, priorities from reading your reports. Because I already read your PT results, I already read about everything about the lab. So I know where the weaknesses are. And we got to look into that. Okay. So now I go there and I'll start reading some of the documents that we asked for. We'll read the quality management plan, some of your QC charts and so on. And here I look at the personnel records. And I see you have 5 pathologists there. Can you please explain to me how you assess their competence? I don't see any competence records for the pathologists. I see for the technologists, 6 months and 1 month. You guys are good at doing that, but physicians are behind.
Is there any things you need to do besides going to the conference or going to a lab ward? Anything else you need to do?
Of course, yeah.
What?
See, okay, so this is new, yes. Good response, because until recently, really that was the attitude. That pathologists are the big shots and leave them alone. They are board certified. They know what they are doing. But we've changed that almost 10 years ago. It was always there, but it was not conceived properly. Now there's a clear statement says you have to have a mechanism by which the professional competency of pathologists is assessed. And that does not mean you have to start a whole new process. Remember, we talked about the quality management program, and we talked about peer review, and we talked about turnaround time. Well, you just use these data to compare pathologists' performance with each other. So you already have peer review, you have a threshold, and you can, for each pathologist, say, well, this pathologist had 1 in 1,000 mistakes or discrepancies, that's acceptable. The other one has nothing, that certainly is doing bad. So there's already a comparison.
Oh, I didn't know I have to do that.
Oh, yeah.
And I thank you for very much for letting me know that I will,
Right.
I will be able to do that. By the way, I just read about a program the College of American Pathologists do for the cytopathology called the Proficiency for the Physician. They send me some slides and we're going to look at it and send them the result. Is that would be acceptable?
Excellent, that's another one. So there are so many indicators. There's in cytology a PT survey for the pathologist, a test. You certainly can use their results as part of their assessment. So you got their peer review, you get their inter-institutional review, like you could take a sample from each pathologist's work and send it to somebody else, a Mayo Clinic or another consultant, and see if they agree or disagree. You take the proficiency for cytology. You take frozen section versus permanent diagnosis if you are doing frozen section. You take turnaround time in GYN and non-GYN cytology. So you already have 4 or 5 indicators by which you can evaluate the pathologist, and at the end of the year you can sit down and make a table for them, just like you do with the technologist looking at their criteria. Here we have it for pathologists, and you can use that to give them even a grade if you want to. You could just make it satisfactory, unsatisfactory, or in some places there is money attached to it. So like in my lab, we give them bonuses at the end of the year, which depends on their performance. It's called performance pay. Many places have that. So it is only fair to look at their work. You could add workload to their performance. Some of them may sign several thousand cases a year, while others may do only 500 cases. It's only fair to reward those who do better. So you can use these criteria either just to assess their competence acceptable or not, or you can also use it for individual performance assessment for the purpose of promotion and something else.
I forgot one more thing, some of our patients go in another facilities, in higher facilities than our in experience, and they are more specialized, and they ask for their reports and the slides of their patients. and I send it to them, and then they send me a report back. Would it be a good idea to review it with my report?
Absolutely, that's excellent. That's one more criteria. This is what we call inter-institutional review or inter-institutional comparison. This is like alternative PT, basically. You see how the rest of the lab, if you don't have a PT, you send to another laboratory to see if they agree with you or not. Well, with pathology is the same. With anatomic pathology, you send it to somewhere else, either intentionally or not. But you get the feedback, you add that just like internal peer review. You got 10% internal review already, now you have inter-institutional peer review. And the same, you count discrepancies. So there are so many tools, you don't have to reinvent the wheel, but all these make a nice set for competency assessment. Okay, so we already here identified at least two areas in anatomic pathology. One is the quality management program, the other competency of the pathologist. Both are deficiencies, but you are going to work on them. And again, one, you probably by end of the day, you will have it. So will be corrected on site. For competency, I don't know if you can have it. You probably cannot do it in one day. So that you'll have to respond to CEP about it later.
Would the CEP allow me like 30 days to respond?
Yes, for every deficiency that is cited, you have 30 days to show them how you are going to address the deficiency. And if it is phase 2 like this one, you have to also show evidence, which means you make a chart showing how you are going to assess competency, and you show them that this is how you are going to do it. All right, well, excellent. Thank you all very much. I think I concluded this part of the inspection. I'll finish reviewing the documents, and we will have our summation conference perhaps at 4 o'clock or something like that. Okay?
Thank you.
We look forward to it.
All right. Well, I'm not done yet. Remember, we had your role in the organization. I'm done with you. It's up to you to stay here. Or you could just stay here, because we'll have the summation with you. But you remember we said we want to assess the organization. So I'm going to have an interview now with the CMO and the CEO, either together or one at a time. Okay, so let's have it together. Maybe the CMO and the CEO can come here. Yeah, let them sit there.
ما اعرفهمش السي او ده هو صاحب المكتب السي او ده صاحب المكتب السي او ده رئيس مجلس
Okay, well, of course we do here the introduction. I have been already introduced earlier, so we'll skip that part. We'll go to the meat of the process. All right, well, I want to thank you for participating in the College of American Pathologists, or at least encouraging the laboratory and paying for the expenses and so on. I want to assure you that the purpose of the process is peer review designed at improving the performance of your laboratory with the ultimate goal of improving patient care. I know you're busy, but I just want to get your feedback about the performance of the laboratory. We look at the laboratory as a member of the team. We like to think of it as a body that is important to you as managers of the facility, of the organization. And we want to make sure they are an effective team player. I've heard from them. You have a great laboratory. The staff are knowledgeable, and wherever they have an issue with the expertise, we are willing to help, and we have sincere and honest discussion with them. But I just want to hear your feedback. So let's start with the CEO. Chief Executive Officer is essentially an administrator. Please just give me your perception of the laboratory. How does the rest of the management establishment look at the laboratory? Is it just a cost center for them, some an expensive part of the hospital, or they see it otherwise?
Of course, as you know, that laboratory is a very important part in the hospital, and they are doing a very good job. And according to some criteria, that about 75% of the diagnosis is coming from the laboratory. So we appreciate their job, and with our communication with them, we realize that the laboratory is really they deserve appreciation, and they're doing very good job.
Okay, well, it's nice to hear that. Just tell me, if they need a piece of equipment or something, how is your process going?
About the machines, you mean?
Yeah, if they need a new machine or a new
Yeah,
maintenance.
actually, we have a policy. If we introduce new machines to the lab, there is some policies we have to check with the cost of the machines and the performance of the machines. So finally, the decision is coming from the lab director. He is the one who is giving us some imagination about the new machines. So we are go ahead. You see what you mean?
All right, great. Well, as you see here, the idea is to make sure the lab has adequate support. So it's a two-way street. We want to make sure they're happy with the lab, but they're also paying back, providing support to the laboratory. That's important to us because I'll get this information. When I go back to the lab director, I will discuss with him these issues if there are any. But sounds good. That's an excellent situation, then a good relationship between management and the laboratory. And it's nice to hear that. Now I'll turn to the Chief Medical Officer. All right, well, the same thing here. The idea now is, since you are the representative of the medical staff, you are the chief of the medical staff of the physician, they are our consumers. So I want to know also the feeling of the medical staff about the laboratory. Is the laboratory responsive to their needs? Does it provide all the testing they need, the turnaround time they expect? What is your feeling?
As a chief technologist, for me, my stuff is the best. So I look for...
You're a doctor, now you're chief medical officer. You are the chief doc in the hospital.
Chief doctor?
Yeah. Yeah.
For the doctor, also I will look for them at first and I will see what they need. For pathology, they need each one, they need microscope, good microscope with camera, with diagnosis. I try to keep them, bring that machine for them so they can diagnose.
What about, so you agree with the chief
Yes.
administrative officer? I just want to know the opinion of the medical staff. Do you agree that the medical staff are happy with the performance of the laboratory? Do you hear any complaints from physicians?
Of course, it must be some complaint, but we will try to do to make everything is okay.
Very good, that's a diplomat. Excellent, yeah, so that's the kind of thing. I don't want to put you on the spot, but this is what we look for with the CMO. We want to know that the CMO is representing medical staff, they are getting the test they want in a timely manner, nobody is complaining about accuracy. So that's important to us to know. And again, it's a two-way street. Let's see, what kind of support does the medical staff or the chief medical officer give the lab in terms of interaction? You heard the lab director, well, not you didn't hear, but for you, you heard the lab director saying earlier that he really doesn't interact that much with physicians. That may not be his fault. It may be that the CMO doesn't do anything to encourage that. We want to change that dynamic. So for here, I would ask, are there forums, functions in the hospital-wide and the organization which brings the lab in contact with physicians or in interaction with them?
We lecture, our doctor make lecture with medical doctor, they make instruction, how if one case, sometimes discuss also cases.
Okay. You want No, that's okay. Yeah. You want to come? Let's share. So sometimes we have more than one CMO. She's your vice CMO. Please come on in. Come on, it's okay. Yeah, maybe we'll discover a new talent and we'll send you to Hollywood. Okay? We'll make a recommendation.
I think there is several ways of communication. One of the hospital council meetings, we can communicate to each other. There is a lab utilization committee. We held it and we communicate through the incidence reports. They send it to us or we send incidence reports to them. There is all the ways of communication.
Okay, excellent. I mean, you touched on a point which I wanted to bring out. How to involve the lab in the hospital-wide operations, medical operations. And these are what we call interdisciplinary committees. And one of them is utilization review, whether things are appropriate, but there are two other committees which are very important to involve the pathologist. Yeah, risk management, part of the quality management. Remember we talked about errors. A major error with impact needs to go to the risk management. There is also a committee which would be helpful. It's called tissue committee, tissue review committee, for pathologists who get specimens for anatomic pathology in your area. Now, if there are too many specimens beyond the threshold, which are not good, somebody has to communicate that to the medical staff. They are not doing good on obtaining proper specimens. That committee should be chaired by a pathologist, or at least co-chair, so they can address this issue. Another committee would be point of care testing committee. If you have point of care, you need to be on board. You need to be the ones in charge. So that's our discussion with the CMO to make sure if they don't have it, to start having it. And they listen to us normally. Usually they're like you, they immediately pretend or jump to say, we will do whatever you say. So that's helpful. So point of care testing committee. Another one is transfusion review committee. If you do blood transfusions, you certainly want to have a transfusion medicine director from the lab running that committee or participating. So these are the kind of committees which we think we would be helpful. So you think in the future you will get more of these committees running? Of course. Excellent. Well, thank you for your time. I appreciate it. Sounds like you have a great organization here and a great laboratory. All right. Okay, so we're done with the inspection. At least the interviews and the check. The next phase of the inspection is for me to sit with the team. If I had a team of several people, the team leader is responsible for the entire inspection. So as I said earlier, I have to keep track of their performance, of their work throughout the day, so we are on time. I promised the lab director that 4 o'clock will be our summation conference. Now in many places he's going to invite the CEO and the CMO and probably other folks to come and attend the summation. So we have to be on time. We don't do it the Middle Eastern way, we do it the standard way. You say it's 4 o'clock, it's going to be 4. You say معادنا الساعة 6 مش تيجي الستة وثلث شيك الأغنية بتاعت نانسي عجرم ما عندنا كان الساعة 6 وهي 6 وثلث أو لازم تكون الساعة 6 بس أوكي فالساعة 4 بيجي السميشن بس قبله يعني before that we sit with the all team members and I listen to each one's presentation. They have to tell me about each deficiency. We want to make sure that nothing is cited that should not have been cited. And after that, if we agree, then okay, we are ready to go to the summation conference. So now I will invite back the lab director and the supervisors and whoever wants to attend to come back to the stage.
Good practice always is to let the lab director know when you have a citation that it's going to happen. So you don't surprise him in front of his hospital administrator and the chief medical officer, so he will know exactly what he's expecting.
Yeah, exactly. Yeah, that's an important point, as you see. Now, they all know what to expect. So as we come to the summation conference, nobody's going to be surprised. This is really just a summary. And they are relaxed, they know their answers, we already discussed with them how to fix the deficiencies. So this is like a friendly icing on the cake. And this way, no matter how many deficiencies there are, or recommendations, nobody's going to have a hard feeling. We remain friends, we help each other, and so on. So at the time of summation, basically, each team members will present their findings. So normally, I let my team go first, and they already finished, they presented whatever, then I go at the end and I summarize or add. So we made, as you saw here, we found a few deficiencies, mainly with the quality management program. The director wrote a new management program, quality management program. I looked at it, and it looks fine along the lines which we talked about. Monitors, pre-analytical, post-analytical, analytical, so that I will put that as corrected on site. There was another deficiency about competency with the pathologist. That's a phase 2. You have 30 days to respond to that, and then you submit it to CEP, and then it will be just fine. We made there a few recommendations. Now, recommendations are optional. You don't have to do anything about them, but it's a good idea to follow them as well. At the summation, if there are too many recommendations, we don't bother repeating them to you, especially if there is management officials who may misunderstand what we're talking about. Otherwise, we can say them again and so on. So at this time, I'll give you the form. Is there any questions or rebuttals or about those deficiencies or recommendations?
Here is when you ask. If you have, here is.
Yeah, if you are in the audience, you can also ask questions, because you could invite the entire laboratory.
Yeah. We're gonna work on the ones that we didn't finish today, and in 30 days we're gonna submit our response to the CAB with the new procedures written and the corrective actions that we're gonna take about them. And in that time, we should get our accreditation.
Any more questions? The audience? Let's say you were attending the summation conference, so this is your time to ask about the whole process. Yes?
If we are reviewing our policies and procedures every 2 years, and this is our frequency, and it's acceptable in our hospital and in our department. So now you said it's annual, you have to review the procedures annually. So we have to make it annually, or 2 years is acceptable?
No, I didn't say you have to make it annually. The minimum is once every 2 years for the inspector to see that each procedure has been reviewed and signed by the lab director. However, you want best practices, right? We're here to help you improve. It's not a competition. It's not, remember, it's not about paperwork. I couldn't care less about paperwork if the performance lacks. You could show me all the documents you want, but you saw how I went to look for myself. I didn't want the supervisor to tell me what is going on. I wanted to see the tube, how he does the work. If the instrument was actually here, I would wait and watch him do the QC and look at the computer and see the results and release the results. And I want to see a printout. I will go through the entire process while I'm standing there. I want him to show the procedure. Remember, I asked, show me where this rejection policy. And I'm going to see the signature or not. I'm even going to check some references. I'm not going to do it on every procedure, but I'm selective. I know where the weaknesses are from reading your report and knowing what you're going. So best practice is to be always ready, not to start scurrying around the last 3 months. And that's best practice. Why? Because the first year, like now you're inspected. What is now? It is March. March of next year, you have to self-inspect, which should be done exactly the way we did it here. You could do it yourself, make a mock self-inspection. This is your review. Well, I mean, the reviewer is going to look at your policies. So this is like an annual review. So if you have to do it anyway, why not then just do it 1/12? But if you want to do it on 24 parts, you could do that if you like. But the best practice is to be always ready, because there are many procedures which change. 2 years, maybe a long time for certain things. Yeah, certain things don't change in 2 years, but there are other things which they do, especially in chemistry, hematology, other areas. Maybe AP, anatomic pathology, doesn't change that much. But blood bank, actually blood bank should be every year. There are things which require more frequent checks. So that's the idea. It's not that you have to do it. This is best practice. It's a recommendation to do it. Remember, I told him I just recommend that you do it like this. But hey, I cannot force you to do it. It's up to you. Okay?
Another thing is the BT testing. Yani our practice, we are not printing all the reports. We are keeping them as a soft copy. And then we are just writing the unconformance. So the unacceptable results, if we have unacceptable results, we have a form, we have created a form for troubleshooting, and we document this form and we sign it. So now you require the report themselves to be signed by the head of the lab or the head of the unit. So we have to print them and sign them.
your corrective action, I mean, there is a form, CAP gives you where to put corrective action. If there is a failure, you must have that form filled with corrective action. Now, the report itself, we need just evidence that it has been reviewed. Again, you have to change culture here. It's not about the paperwork. We're not here to chase people for a piece of paper or not. The idea is the spirit. Did the lab director actually read the report? I want to see evidence that the lab director read the report and had an input. Not to tell me like, remember how we started, the lab director suggesting, well, I leave it to the quality manager. That's not acceptable.
So here the lab director is delegating for the units, the heads of units are delegated for all the different specialties, because the lab director is not the specialty of everything. Yeah. So he cannot see, it's out of scope to go through all the BT of the whole, all the 4 specialists, for example. So he delegated this job to the head of the unit. So the head of the unit, now the reviewing is substituting the lab director.
No.
Acceptable?
The answer is no. Remember the delegation, there is a checklist, check item in your checklist about the lab director, about delegation. What does it say about delegation? You must, the lab director must make sure that those to whom a function has been delegated do their job. He has to review what they've done. So yeah, he can delegate to somebody, but he has to review after them to make sure they have done the job. In other words, I'm not an expert in blood bank, let's say. So the director of the blood bank reviewed the PTs and wrote notes. I still have to read his or her notes and sign over on them. That's how it works. That is lab director's involvement. Want to say something?
Yeah, the lab director is the pathologist. The pathologist who is a physician. He has to look in the results, the impact of the errors, and he has to evaluate how he's going to go after that.
Everything.
Correct.
Right, everything. For us, the lab director was a physician. Usually, in the US, a lab director must be a physician, with a few exceptions. But whoever is designated a lab director must make sure that all these items of quality management, especially PT, are reviewed by the lab director and signed off. He can delegate, but he has to make sure the delegation is appropriate.
So is it acceptable to, because we're thinking about this, to prepare like a table with the number of the specimen, for example, the cycle, the number of the specimen, and then reviewed, if it is all acceptable, no corrective action to be taken, and then signed by the head of the unit and then the lab director.
Yes.
And we have another form for you prepared for the unacceptable results, where it has to be detailed and corrective action is mentioned and then signed also by the head of the unit and the lab director.
You could have different forms. Yeah, the spirit, again, like I said, is to have a documentation or proof that the lab director is involved. However, when the inspector, an experienced inspector, can read between the lines, if I see all your PTs, all your documents,
The same day.
with same day, no single word from the director.
For the inspection.
Nothing. The director just signed on the word reviews with 2 letters, initial. That's not the lab director's involvement. I have to see evidence that's reviewed. That's why my suggestion is, even if you have 100% success, the lab director has every now and then to look at it and say, yeah, this is an educational challenge. Although I don't have to achieve 100% or whatever, nevertheless, we looked at it, even educational challenge. So I want to see evidence of the lab director's involvement. So the habit of just having everything listed and the director signs, although it is in principle okay because there is a signature, however, if the inspector detects foul play, that this is not real involvement, the inspector can cite that as a deficiency or at least a recommendation. Now, recommendations, like I mentioned, they are for your eyes only. I mean, you can ignore them if you want. However, when they go to CAP, the staff reads them. And although I made it a recommendation, the staff may change it into a deficiency if they feel there is a systemic problem, like this. If they feel that, oh, this lab director is not doing anything, they will say, no, you cannot cite this as a recommendation. It has to be a deficiency. We want to see evidence of the lab director's involvement. So in CAP, there are so many layers. It starts with you, then with the team leader, the inspector, and then it goes to the staff. And even after that, it goes to the regional commissioner. So there are layers upon layers of making sure that here we are not goofing off. This is not about paperwork. This is about real patients, real quality. And it will be code. Well, guess what also? On top of all that in the United States, a certain percentage of our inspections are reviewed by CMS, by the Centers for Medicaid and Medicaid Services, by the federal government. A certain percent of CAPS inspection is inspected by the government to make sure that their findings match our findings. Of course, they are not going to inspect you because you are outside the United States, but I think your governments are going to follow the same thing at one point or another. So you're going to have even a higher layer of involvement. That's why our advice is from the start, don't think of documentation as an exercise in good paperwork. Think of it as an exercise in good quality. We want the director involved. Chase them. Be involved in quality management. If you are a technical supervisor, don't accept the responsibility of doing it yourself. Get the lab director to be involved. He or she has responsibilities. You could teach them, tell them, this is what I'm doing, I need your help. Go call Dr. Basta, go Dr. Omar, go somebody and get more information, help us out. So get them involved, they will be thankful. And I think here Dr. Basta demonstrated how an excellent response would be. Oh, this is a good idea, we can do it. Remember how? And that's what we expect people to take it in good spirit. The inspection is not a policing action. Your preparation is not a preparation to get out of jail. It's really a preparation in doing things better. Makes you feel good about the quality of work you do. Okay. Any other?
Can I ask one question, please? For CAP team, they have any inspection for the pre-laboratory errors?
Pre-lab.
Pre-lab.
You mean a nursing station?
Yes.
Yes, of course. We look at the entire process. As you saw, I started with the specimen. Now, if this was a real lab, I would start at phlebotomy. And if your phlebotomy is done by nursing staff, I'm going to start with them. Yeah, I'm going to watch them actually do an actual phlebotomy. Lab.
There's a checklist for that.
Yes, there is a checklist, of course. And we hold you responsible for phlebotomy. Even if the nursing staff does it, we hold the lab director responsible for making sure they follow CAP, quality assurance standards for phlebotomy. If you have point of care testing, right? The glucose and things like that done by nursing staff, the same thing. We expect every nursing personnel who does an iStat or one of those devices to follow the same standards of quality. They must have annual competence, they must adhere to pre-analytical ID, specimen ID, everything, just like lab personnel, and we do inspect them regardless of who they are. In the blood bank, we actually follow the blood unit, at least 1 or 2 blood units, all the way to the patient. And we will watch how it is being transfused. And we will wait at the end of the day to get a post-transfusion report form telling us how did the patient do after transfusion. So for us, like I said earlier, it's a patient, it's not a specimen. We are going to make sure the specimen in our hands or a blood unit has fulfilled its intended purpose, which means serve the patient. So we're going to follow it all the way to the end. So yeah, we will do, and as you saw here, we are inspecting the CEO and the CMO. It's not a joke. I want to hear from them because one of our standards in the lab director's checklist says, does the lab director have sufficient authority to implement CAP quality standards? We understand there are administrators who are micromanagers. They want you to follow their ideas. Well, that's their problem. Our problem is to make sure that the lab has what it needs to provide good patient care. So if I detect in the interview that there is a reluctance from the CEO or CMO to provide enough support to the laboratory director, we will cite that as a deficiency. And guess who needs to respond to that? The CEO. Because the lab director will take it to the CEO and say, look, CAP cited me for this deficiency. You want your lab to be accredited? Hey, tell me what to do. Then he has to provide you with the support. Okay. Yes.
Yeah.
Okay, one more question.
I'm Dr. Tariq, I'm cytopathologist. As you said, the pathologists are big shots. And what I noticed that the quality which is important in pathology than the quantity. When I was starting my cytology, I used to see many cervical smears, say more than 2,000 a year. But when I started my FNA and CSF for patients with leukemias, I think the quantities had reduced too much. I mean, to 500 to 700 a year. So it is not the quantity, it is the quality,
Yes.
which we have to look
Right.
for.
That's why you remember how many parameters we talked about. We talked about peer review. We talked about turnaround time. We talked about PT and cytology. These are all criteria by which the pathologist should be judged. We talk about histology, cytology correlation. So all this is about quality, yes.
Thank you.
In the US for the cytology, for the cervical pap smears, I get a test every year. 10 slides with I don't know any answer on them. I look at them, write my answer, send it to the CAP. If I don't pass it, I cannot see cervical specimen until I pass the test.
This is for all
It's an
US.
external quality control.
Yeah, this is for all US
For
pathologists.
all the US
We
pathology.
all pass, we have to pass that test.
Yeah.
Okay, very good. Well, I think we reached the end of the line here. Thank you very much. Great actors and ladies.
Thank you for your attendance. Now we would like to thank our speakers of the day, and certificate of appreciation will be given by the chairperson, Dr. Ma'moon. So we would like to thank Dr. Rawhi Omar. Thank you very much. Now we would like to thank also Dr. Napil Basta. Thank you very much. Thank you very much for your attendance. Thank you.